PSMA is a cell surface antigen expressed on the vast majority of prostate cancer. Roughly speaking, 90% of metastatic castration-resistant prostate cancer will have most of their tumors express some PSMA. That's a broad statement. We can target PSMA using small molecules or peptides or ligands, that are synonyms, or antibodies. We have a long history with antibodies, but as the small molecules were developed, we wanted to assess that, and no one had ever done a dose escalation study of a radiolabeled small molecule. Lutetium PSMA-617 is the most common PSMA-targeted small molecule that now has actually completed 2 randomized trials in terms of enrollment. We don't know the results. So while those data are becoming mature and with expectation of approval, we wanted to really look at how to optimize the dose and schedule. So we did a dose escalation study really reflecting our prior work with the antibody J591 with a fractionated cycle. So 100% of the dose is given in a single cycle, day 1 and day 15. Last year at ESMO, we presented the phase 1 portion of the study where we went up to the highest planned dose level, which was 22.2 gigabecquerel per cycle. Without a dose-limiting toxicity, we decided to stop rather than going up, and then we subsequently enrolled in the phase 2. And what we presented at the 2019 ESMO conference is the combined analysis of the phase 1 and phase 2 trial, where overall those 44 patients were treated without without selection for PSMA. So everyone had a PSMA scan entry, but that was not used to define the criteria to treat. And overall, it was around 81% had a decline in PSA. And at the dose that we think is right based on the phase 1, which is 22.2 gigabecquerel, about 2/3 had at least a 50% PSA reduction. There was a dose response. So the dose administered was related to response, progression-free, and overall survival. And then retrospectively, looking at the baseline imaging, that was also associated with response, progression-free, and overall survival. So those that, even though we didn't use PSMA expression as a criteria to get in, those that had some PSMA lesions that were greater than 5 times the liver uptake tended to do better with the PSMA-targeted radiation, which does make sense when there's more of the target that is there. So we're finishing the enrollment at the second site with that trial and hope to have an optimized dose and schedule of that particular drug, as well as looking at tumor imaging and immune biomarkers ready for when this drug gets approved.